morning again, everyone. Welcome to today's session, Clinical AI Beyond Documentation. My name is Shu Xiaoyi, and on behalf of CSP London Regional Network and City St George's University of London, we are delighted to have you with us today. When we talk about AI in healthcare, the conversation often centers on administrative efficiency, things like automated note-taking or scheduling. Today, we want to move beyond that and explore how data and strategy are transforming our clinical practice and service development, taking AI from the back office into the clinic to enhance patients' outcomes and support our professional reasoning. So before we dive in, I'd like to introduce the CSP London Regional Network Committee. Our leadership team includes myself as a chair, Harjit as our vice chair, and Lawrence as a core team member. And we are currently recruiting new core team members. The London Regional Network is a community-driven network whose mission is to foster professional excellence and support London-based physiotherapists to navigate many resources available to them. If you'd like to learn more about what we do, how we develop distinctive skills, and how you can make a real impact on professional development, please stay on after the event for a very short recruitment session. You can also find us on Blue Sky and LinkedIn. We'd love you to join the ongoing conversation there. So a few housekeeping points. When you join this event, your camera and microphone are automatically turned off, and we would appreciate it if you could keep them off throughout the session. This session is being recorded for those who are unable to attend live. If you experience any technical issues, please try rejoining the session or checking your internet connection. Each presentation will be followed by approximately 3 minutes of Q&A. You can post your questions in the Q&A chat box during or after each speaker's presentation, and we will prioritize the most upvoted questions. After all the presentations, we will bring our speakers back together again for a panel Q&A. If you would like to speak to our speakers directly, please use the raise hand feature so that we can invite you to unmute and ask your question. So on screen, you can see the agenda for the next 2 hours. We have a packed and exciting agenda, beginning with the introduction and followed by presentations from our 4 guest speakers. Each presentation will last approximately 10 to 15 minutes, followed by 3 minutes Q&A, as I mentioned earlier. So the final panel Q&A will be approximately 15 minutes. We hope to give you direct interaction with our speakers. Before we close, we will invite you to scan a QR code to share your feedback for the event. If you would like to hear more about clinical AI projects, resources, fellowship opportunities, or potential collaborations, you will also have the option to leave your contact details and share your ideas so that we can provide information tailored to your interests. And this is open to everyone. So once the events finish, you can choose to stay on briefly for a 10 minutes London Regional Network core team recruitment update. So what does beyond documentation actually look like? Here are some examples. In radiology, AI-enabled diagnostics, particularly for stroke detection, can reduce treatment times in NHS by more than 1 hour. In the world of MSK, computer vision tools that provide precise gait analysis and real-time form correction that was previously only possible in a high-end gait lab. AI can also involve predictive analytics to identify a patient's risk of falling or hospital readmission, as well as remote monitoring through wearable devices, giving us a continuous view of recovery rather than a 20-minute snapshot in clinic. This is a shift from an administrative AI to clinical decision support. So why are we talking about this now? This is because we need to have more proactive engagements. We could be involved in shaping how these tools are designed and implemented so that they support clinical effectiveness, safety, and ethical practice. So by developing digital literacy now, you are not just improving efficiency, you are also gaining the insights needed to recognize future leadership and research opportunities. Clinicians are uniquely positioned to bridge the gap between technical teams, such as engineers and data scientists, and the realities of frontline care, ensuring that innovation is grounded in patient needs and real clinical workflow. So to bring that clinical shift into real professional context, I'm now handing over to Euan, who will explore how AI is already showing up in physiotherapy practice, where the opportunities and boundaries lie, and how the profession can help shape what comes next. So Euan McComiskie is a digital physiotherapist and health informatics lead at the Chartered Society of Physiotherapy, with over 8 years shaping the profession's digital strategy. He also serves as clinical lead at ORCA, supporting the safe use of health apps, and is a fellow of the British Computer Society, currently completing a PhD degree in digital healthcare education. His work focuses on applying AI and digital innovation in clinical practice. So let's welcome Euan.
Thank you very much, Shu, and I will just share my slides. So hopefully everybody can see that. Is AI the future of physiotherapy? Somebody give me a thumbs up that we can see that okay. Yeah, happy days. So thanks very much for the introduction, Shu. Good morning, everybody. Thanks for joining us on a Saturday morning. As Shu said, I'm Euan. I'm the health informatics lead at the CSP. I'm a Scottish physio who lives in Northern Ireland, but my role covers the whole of the UK. I've been a physio for nearly 20 years now and working in digital and informatics, in some guys for 15 of those years, initially as a departmental rep and then representing the profession and other AHPs in my health board, then leading for digital for all Scottish AHPs, and now for the physio profession across the UK. As Shu said, I'm also a fellow of the British Computer Society, previously an elected member of the UK Chief Nursing Information Officer Advisory Panel, and involved in many other advisory and consultation roles to various organisations and research. I'm also doing my PhD in digital education for AHPs at QMUL. In those roles, I've had the great privilege to be amongst conversations with subject matter experts on how and where AI is being used or could be used in our profession. I'm going to share some of that experience with you this morning. So these are just a snapshot of the headlines in the last few months alone. It's not of the physiotherapy media, but of the wider media. Technology being used across all sectors. Trials of AI-led physio clinics, AI being used to address waiting times, huge investment in AI-supported physiotherapy platforms. I could have filled 5 or 6 slides just like this. And it's a global phenomenon as well. There are stories here from the USA, from Australia, Switzerland, India, Singapore, and of course the centre of the universe, Scotland. Technology is big news in physiotherapy. AI is everywhere. Now, forgive me for quoting some American data here, but comparative data is just not available for the UK market. And just to point out, there are some subtle differences between physical therapy in the USA, but it is largely the same as our version of physiotherapy. And you can see that the AI market in physio in the USA is predicted to break the $200 million mark this year and to exceed $1 billion by 2033. AI is an enormous deal in physiotherapy, and it's only going to get bigger. Back here in the UK, last summer, NHS England published their 10-year plan for healthcare. There are 3 shifts that they're seeking to deliver: illness to prevention, hospital to community, and analogue to digital. In the document, there is a huge focus on digital, with the word digital being mentioned 120 times across the 171 pages of the plan. Technology is mentioned 164 times. Data is mentioned 183 times. AI is mentioned 107 times. And to put those numbers into perspective, physiotherapy is mentioned only 4 times. Now, we can talk about the marginalisation of physiotherapy and other HPs in healthcare policy in another session, so let's focus back in on digital. So how digital are our workforce? Well, working in healthcare is one of the best predictors of poor digital skills. Not age, not profession, not career level, not education level, just working in healthcare. Ouch. An Ipsos Mori study completed in 2022 showed that we still have some way to go for universal digital competence across the healthcare workforce. Nearly 2/3 of healthcare workers in that study were found to lack at least one of the 20 most basic digital skills, things like attaching a document to an email, things like opening a web browser. And we see that specifically in AHPs too. After the UK AHP Digital Competency Framework was published in 2021, my friend and a fellow physio, Chris Tack, was the lead author of a paper alongside a squad of other AHPs, Leslie Holdsworth, Alex Wilson, myself, Pippa McCabe, Wendy Wilkinson and Matthew King. We completed the survey in the latter part of 2021 and then published our results in early 22. We found a pretty damning picture of digital competence across UK AHPs. A snapshot of that is included on the slide here. And can I draw your attention particularly to the competence question around AI? 80% of respondents reported that AI could be applicable in their work, but 76% reported low or very low competence. Remember that stat. But there was some hope, with an average score of 8.4 out of 10 for motivation to use digital tech at work. However, it's not just individual competence that is limiting HP progress in the digital world. There are significant logistical, systemic and relationship challenges to overcome as well. The systems that we use do not do all that we want them to do. And at times, our clinical processes and procedures are actually limited by what those systems can do. And we frequently don't know how to influence change in the systems that we do use. Now, not published yet, but we did do a similar survey in 2025, and the early findings show a significant improvement in competence around AI, but still 32.5% of our workforce reported low or very low competence in AI. So despite their motivation to use digital technology in their work, the systems get in the way of how AHPs work, and there are gaps in our competence level. So with these rocky foundations of data, competence and infrastructure in mind, are AHPs currently using AI in practice? Well, yes, they are. Now, it might be utilising AI to support data analysis when we know that there just isn't enough analytics workforce to support all our needs in the NHS. It might be using AI to manage our ever-growing waiting lists, or using tools like Copilot to support our administrative needs to save us some vital times in our ever busier days, or using AI to support ambient voice documentation tools like Nuance or T-Pro to allow us to have more meaningful conversations with our patients, their families, and our own team members. Or maybe using slightly simpler AI tools like Heidi to support our documentation needs, especially for our members who require additional support with their documentation. Or using AI-powered search engines like Consensus to locate research articles, or evidence synthesis tools like Notebook to turn that evidence into reports for different audiences or other media outputs. Or it might be using AI to enhance simulation-based learning in practice or in an education setting. AI is being increasingly used in physiotherapy. It may still be the exception rather than the norm though. So what is holding us back? We've already spoken about some of the human factors around acceptance and adoption of AI, but what else is stopping us? The first thing I want to talk about is data. AI is a voracious consumer of data. It needs huge volumes of it to power even relatively simple algorithms. We've heard already about the policy push towards more data-informed services from the 10-year plan. However, we've also heard about our lack of competence in the AHP workforce around data. And work led by the Community Rehabilitation Alliance in 2022 showed a data deficit for HP services in the community. Our acute primary and secondary care colleagues aren't much better off. If we as a profession are going to move to more AI-enabled services, then we must have a more robust, more consistent and more comprehensive data set than we currently have. The next thing I want to talk about is regulation. I promise not to get too political, but after our good friend Brexit, the UK severed ties with a number of EU legislation. The EU is pretty well served by the AI law, whereas the UK is not. The other side of the Atlantic sees America being much more open and inviting collaboration between government and AI companies without the tight legislation of the EU. So in the UK here, we're quite literally caught between the two. In the UK, we are lacking some legislation that crystallises AI as a technology, and within it what is permissible, regulated, mandated, etc. Without that legislation, it leaves quite a few grey areas, too many for my liking, and that is a space that innovative and entrepreneurial people are flooding. Most with very good intention, and it should be noted that quite a few of those are essentially over-regulating their products to demonstrate their intention for best AI practice even where the legislation doesn't yet require it. The third thing I want to talk about is sustainability. I mentioned before that AI requires huge volumes of data. This data processing comes at another cost though. 1/5 of the island of Ireland's energy usage comes exclusively from data centres. That includes their high electricity usage, but also their vast water usage to feed the cooling systems. 1/5 of the island of Ireland's energy usage from data centres. That is an incredibly big number. We have no longitudinal data about the environmental impact of AI as we just don't have enough data of its current use. So we're reliant on mathematical modelling, largely shaped by AI, of course, so a huge conflict of interest. The energy used by these data centres is infinitely bigger when developing generative AI tools like ChatGPT and Claude than it is for incidental use by you and I. That incidental use actually has a negligible energy cost. But the scale of use is growing larger by the day, so we must be aware of the environmental impact of our use of AI. The last thing I want to talk about is education. The CSP surveyed the 60+ universities that offer pre-registration physio courses in the UK in 2022, and all of them self-reported including some aspect of digital in their curriculum. But it won't be until later this year, and as part of a significant review of the quality assurance of the UK physio curriculum, that digital will be mandated as a constant thread across different module content to achieve the graduate attributes of the CSP education reform and the HCPC standards for education and training. Huge progress, but long overdue in my humble opinion. But the surveys we conducted demonstrate a gap in our current workforce competence. And if we're not mandating the inclusion of digital in our undergraduate curriculum, how can we expect our profession to have the knowledge and skills to work with AI in their practice? I wrote a piece about AI in the summer of 2023 for the CSP website and in the Frontline, but it's still as valid now as it was nearly 3 years ago. The story of AI in physiotherapy is more currently about potential than reality. There are some excellent uses of AI like we've seen already and that you might be currently working with, but there are still concerns about trust, infrastructure, competency, regulation and other things getting in the way of it being the norm in our profession. In my lifetime, and I'm only 42, I cannot see AI replacing a physiotherapist. But I do expect that an AI-enabled physio will absolutely replace one who is not, and it's our choice which side of that equation we choose to fall on. We also need to understand if the people want it. Would the public prefer to be treated by a human or by AI? Would their expectations change if they were? Would they be content with an AI physiotherapy experience? Do you know what your patients think about AI? And what about the rest of the workforce? Do we understand AI? Do we want AI to support the work that we do? Are we comfortable to give some tasks to AI to allow us to focus on the things that we are better at or the things that we enjoy more? The Health Foundation published an excellent paper earlier this year on the public and NHS staff perceptions of AI. I've shared the link on the screen here, and I'll share it amongst the resources at the end of the webinar as well. I'd thoroughly recommend that you have a read. Lots of very interesting content and challenges to many assumptions that you might have. It certainly challenged me, and like any good piece of research, it posted as many questions as it did give answers. At a professional body level, the CSP released the second edition of our AI principles earlier this year, and there's a link on screen to those. We plan to update them again later this year, so please keep an eye on the CSP comms channels for those updates. The second edition of the principles is larger and deeper than the first, so expect more of the same for the third edition. They may not provide all the answers that you have around AI and physiotherapy, but they will help you to structure the questions to ask of AI vendors, of tech experts in your organizations or other organizations as you begin to explore the possibility of implementing AI in your practice. So I started my presentation by posing a question to you all. Is AI the future of physiotherapy? What I've shown you hopefully presents an alternative hypothesis that AI is present in the current version of our profession, so we don't need to wait until the future. However, it's our choice how it shapes the future of our profession. It is us who must balance the potential and reality of AI. It is us who must see through the hype and balance the hope with the secure foundations of governance, regulation, trust and competence if we are to deliver AI-enabled care just as NHS England spoke of in the 10-year plan. There are things in our power to address, like our data, our competence in AI, understanding what our patients expect, and to explore the cultural and behavioural change we need to affect if we are to push forward. Some things are out of our direct influence, like AI legislation, AI and healthcare policy. The CSP will continue to lobby on your behalf for this to be considered by central decision makers. Leave that to us, while you focus on the things that you can impact. Like I said earlier, I can't see a physiotherapist being replaced by AI in my lifetime, but an AI-enabled physio will absolutely replace one who is not. It is in your power to decide which side of that balance that you want to be on. I look forward to contributing to the Q&A section right now and then later on in the morning as well. Thanks to Shu and the London region for inviting me to speak, and look forward to any questions. I'll stop sharing now.
Thank you so much, Euan. So we have a question for you. Can you explain more about consensus, and is it available to individuals outside NHS and Notebook? Does the new NHS Digital Academy cover the use of these tools?
So I'll start with the last bit. Does the NHS Digital Academy, and I presume you're probably talking about the Digital and Data Foundations module that's within the Digital Academy, and the answer is no to that. The reason being that the Digital and Data Foundations course that the CSP developed is for foundation level learning, which means that AI is not at that level. What we're talking about is concept of building data. So no, it doesn't cover it in the Digital Academy. There are courses coming to talk more about AI in the Digital Academy, so look out for that. Is Notebook free to access? You need to have a Google account, a Gmail account, and then you can access it for free. You can pay for AI tokens, they're called, which tops up the different features and the functionality that you can use within Notebook. But the core, the basic version of it is free to use if you've signed up to a Google account. Consensus, there is a charge for using Consensus. So it is available to individuals inside and outside the NHS, but they need to pay for licenses to get it. What the CSP are working on right now, and my colleague Chris Tuckett is working on it, is to look at different ways of using AI to create these live scoping reviews, these live evidence reviews for different topics. So that work is happening behind the scenes right now, and as soon as we're able to bring that out to membership, we will. But I expect that probably towards the end of this year, because there's quite a bit to go in terms of licensing use and checks and balances, as well as just the technical aspects of it. So we're looking at how at the CSP we can support you as our membership with getting access to some of these tools. It may not be consensus that we're doing via the CSP, but there will be something coming, as I say, probably later on this year. So yeah, consensus is a fantastic tool, and what it does is it does the hard work of an evidence synthesis for you. It does relatively simple versions of a scoping review or a literature review for you. It's not perfect. There are some errors in it. So just like any other, review, you need to still critically analyze it and appraise it. Don't accept it as the absolute gospel truth. But it is a good tool to have in your toolkit. Just don't ever be fully reliant on it. Use it, but also use what's between your ears to critically appraise things as well. And it's just like any tool that we use, we don't want to be completely reliant on one single thing. So consensus, notebook, and other tools are great to have in the toolkit, but don't be fully reliant on them.
Brilliant. Thank you so much. It's really exciting to see new tools on the way. Thank you, Euan. We will bring Euan back around 11:30. Is that okay, Euan?
Yeah, absolutely.
So if you have more questions for Euan, please join us in the panel Q&A later. Thank you, Euan, again. We will see you at 11:30. So I'm sure you've gained loads of information from Euan. So now let's move on and introduce our next speaker with hands-on experience in a clinical AI project. Chris is a physiotherapist with NHS England and a musculoskeletal therapy lead role at University Hospital Dorset. And he is an NHS fellow in clinical AI. He has supported deployed the Brave AI risk stratification tool across primary care in the Southwest region, supporting safer AI-enabled workflow to improve patient care. His work focuses on digital clinical safety, AI-driven risk stratification, and building AI literacy. So let's welcome Chris as our next speaker.
Hey, thanks for having me. Let me put some slides up.
Thank you.
Okay, I can't see you, so shout if anything goes wrong. But essentially, I'm going to talk about, I've got two remits to talk about today. One is about the deployment project, which I was involved in as part of my clinical fellowship in AI. And it was really interesting listening to the end of Euan's talk there, where he was talking about some of the challenges that we face. And I will go on and talk about some of the challenges in this particular project, and it's interesting how they're kind of mirrored, and we see them as less theoretical in this particular example. So Brave AI is a risk stratification tool. It's a machine learning algorithm which is based on numeric primary care data. So it's looking at pretty much any numerical data that it can pull from the primary care data set. So it can be anything from blood pressure results to numbers of appointments with the GP, to contacts with urgent care, to medications. And it uses all of that data to then model a prediction as to someone's risk of unplanned hospital admission, which sounds fantastic, doesn't it? So the aim of this piece of software was to target the delivery of proactive care to patients who are considered at high risk of emergency admission, and in turn look to reduce the burden on acute hospitals. And that there's a sort of a bit of an intended flow for this piece of software. So a clinician would then have access to these risk scores, would be able to review those scores, choose a selection of patients of which they believe they can make the biggest impact, review via an MDT and in context of the medical records, and then provide some kind of package of outreach for proactive care, which may be different in different circumstances, which is then reviewed and agreed with the patient with the aim of reducing their risk of admission to an acute hospital. So it sounds fantastic, and I guess what's key to say about this particular project is this solution was already developed, had gone through some validation and was beginning in deployment when I became involved in this project. So this is a bit of a a screenshot of the interface which the primary care network would see. So would be deployed at a PCN level, but would be filterable to different GP surgeries. And so clinicians could then look at populations across PCN or within individual surgeries accordingly. There are a few nice tools within it. They could filter to particular groups of patients. So if you wanted to look at patients with cardiovascular disease in particular, then you could do that. If you wanted to target heart failure, you could do that. These sort of views are becoming quite familiar, aren't they, in terms of we're seeing lots of business intelligence type dashboards available in practice now. And I suppose moving on to the next slide, this is where sort of the machine learning algorithm starts to give some insight. So this is all pseudonymized data, but essentially is looking at a population of people across a primary care network and looking at their Brave score, which is essentially, in a simplified way, a 0 to 100 score of their risk of admission to emergency hospital to an unplanned admission over over the subsequent 12 months. So you can look at that and you can say, okay, I've got a list of my people there who have the highest score. So top one on there, 24-year-old male with a Brave score of 96. His risk of admission to acute hospital over the subsequent 12 months looks to be super high. It's almost certain that he's going to be admitted to hospital. And the graph then gives a bit of an idea about what someone's current Brave score is versus what their change in Brave score is. So you could look at rising risk as well as snapshot risk, which is really interesting when you're looking at a cohort of patients across a primary care network. There were a few other tools where you could look at risk scores in the contexts of high intensity users. So that graph on the left is looking at people who have high numbers of interactions with the GP surgery, and also polypharmacy with the graph on the right. So the idea behind this was to target different aspects of, I suppose, economic gain in reducing the number of appointments that people are requiring within primary care. And then on the right-hand side, I guess looking at the resource that you could deploy in terms of non-medical care pharmacist support to be able to manage some of this risk with people. At an individual level, the algorithm gives a little bit of information around how it's weighted its scores. So in the bottom left there, that colourful graph is giving some kind of view of the weighting that it's put to rising risk of mental health as an example on there. So between the May and the June, something's changed in that patient's mental health data, which has added some weighting to the risk score. And similarly, you can see declining risks within that. I think the key thing, and I'll come back to this as we go through, but I think the key thing, the message that we've needed to get across to clinicians as part of this project is this isn't true explainability of the AI algorithm and cannot be used in a diagnostic sense. May give it a bit of an indication of where the MDT might want to spend its time looking at clinical records, but couldn't be considered to be particularly accurate or insightful. But it does give you an idea of their risk over time, and so this particular example, you can see from as we go through June, that risk has risen significantly, and so as a clinical team, you can then look to delve into why that is and what you may be able to do about it. So my role within this project was really around translation of the tool itself and how that is then applied within a clinical context, both in terms of practicality, appropriateness, risk, and benefits realization. So one of the most significant ways in which that was, we had to work on was mapping what the pathway is for using this type of technology, and how that may be used to greatest effect. I'm sorry, this might be quite small on screen, but essentially this was, this is a pathway map which was delivered in collaboration with Primary Care Network to then look at how they look at Brave scores how they then may stratify the use of those scores to target the most appropriate clinicians to then review that patient, and then how that kind of plays through in terms of the standard clinical care delivery and documentation. So this was really interesting. This example that was taken from a PCN was looking at scores of greater than 35 as something that then needed to be discussed via an MDT meeting, and scores below that may be just reviewed by a single clinician for appropriateness for proactive care. I guess I'm just going to nip back to this graph here, because the on the surface you'd look at it and you'd think, okay, well, I just, that's my top 10 patients. Those are the ones I need to target. It's not really the case in practice, because often the patients that have the highest risk may be the patients that you're already aware of, patients that you've already spent time as a GP network optimizing as best you can. The rising risk is an interesting one, but actually, looking at someone whose risk is rising the most, they still might not be scoring particularly high on their risk of admission. So a lot of the skill in trying to deploy this clinically is in where you choose your boundaries for your target population, and how you appropriately identify them, so that we're not deploying proactive care in areas where it's wasted. Okay, so before we could move into deployment, we really needed to look at what the governance and assurance methods are for these types of technology. A lot of the instances that we see of AI deployment in the UK will be in single organisations, and then in this instance, very different. We're deploying across primary care networks, across individual GP surgeries, which are standalone businesses in themselves, and across systems. And so the levels.
It's working.
Oh, I'm sorry.
Someone's mic is, but can everyone mute
Lovely.
their mic, please?
So essentially, we're looking at multiple levels of assurance. So I was working within the purple part of this, the regional team, where we would be carrying out activities such as template documents, clinical safety, overarching clinical safety case work, and support for localization, to provide that regional assurance that this is a safe and appropriate to deliver technology. You'd then have to go through assurance at a systems level, so ICBs and their digital teams and their CSOs then reviewing the technology and providing sign-off. And then you'd have the kind of PCN or the more local assurance, where we're then spending time upskilling the clinicians and the management teams for within PCNs around the deployment, the clinical safety aspects of it, and their ongoing responsibilities in monitoring and assuring that the software performs as you'd expect, and continues to perform as we'd expect in a safe manner. And so this took a deployment flow that we developed across the course of the program. So PCNs would first of all express interest in adoption of the technology. The ICB would have to endorse that and support the clinical safety case that the region has developed. And then they would each complete an MOU and a data processing agreement. So, just some prerequisite work before we could even start to think about local deployment. And then we'd move into readiness meeting. And this is really where the clinical aspect of it really starts to come in, because it's around preparing the PCN to think about. It's not just something that you can point and shoot in your PCN. You need to really consider how you're going to deploy this, how it's going to sit within your operational workflows, what capacity you've got to deliver proactive care, what you're going to do with the duty of care that you develop from having reviewed these patients, and how you're going to document and code the use of an AI algorithm in risk stratification. That then kind of sort of moved on to looking at the data that was available via the PCN. So every PCN, every GP surgery may be slightly different. Sometimes in the clinical documentation systems that they use, but also in the way that they code they carry out their clinical coding and other factors, and this can affect the data quality. And so the vendor of the technology would then review the quality of the data, check that it's is acceptable, and issue this certificate of analysis. And then we move into a training period. So I won't spend too much on machine learning, but essentially it's a centrally trained algorithm, which is then locally fine-tuned in each PCN. And so there'd be a training run whereby the local data for the PCN is used to fine-tune the algorithm, and an AURC value is then identified and considered. So there was a 0.68 threshold for deploying in any PCN. For those who are not familiar with AURC, major oversimplification, but if you think about 0.68, meaning that the algorithm is making the right decision 68% of the time. So anything above that was considered acceptable, anything below that was considered unacceptable. But this is a really interesting point to make as clinicians, is where you set that acceptable clinical risk. And it'll be different for every project because it depends on the impact and consequences from a false positive or a false negative. In this instance, a false positive would involve the erroneous deployment of proactive care. And while that's not efficient in terms of service delivery, there's minimal clinical consequences for that. Whereas if you're talking about something which is identifying someone who's risk of death in the next 24 hours, that's a much greater significance, isn't it? And a false negative in that scenario could be catastrophic. And so it's a real clinical decision as to where you set the threshold for where the acceptable use of these technologies is. And then we'd move into go live, standard operating procedure development for PCNs locally. And one of the key bits around this was in setting, we call it buckets as part of the program, but helping PCNs to set the limits on how they interrogate the data and where they target, which populations they then choose to target. And some of that was based around high scores, some of that was based around rising risk, and some of it was based around high intensity. But a lot of the discussions really came down to what resource the PCN had available, and what professionals they were able to deploy. So was that FCPs? Was that that they could most readily deploy? Did they have availability of their pharmacists to do these polypharmacy reviews? Were they targeting particular diseases and so then needed to link with other parts of the system for support? And this all then led into user acceptance testing, and in most cases, clinical go live. And then finally, the clinical fellow support was around this 16 weeks post deployment support. So with some PCNs that this involved ongoing funding, with others not so much, but enabling them to set some parameters around their benefits realization as a PCN, maintaining their confidence within the technology and trying to help them problem solve any deployment issues that they were finding. And then we did develop a community of practice from this through mainly facilitated through generic meetings and then more targeted action learning sets. Ooh, there we go. Hopefully this runs, but this is just looking at the deployment across the southwest over the course of the project. So green is clinically live, yellow is technically live but not in use clinically yet, and red is not live at all. So over the course of that project, we did see reasonable spread across the southwest region, and very few sites that were not progressing in deployment, which is great. But there were some significant challenges. So data quality was a really interesting conundrum across the geography of an entire region, because the data quality was different in different PCNs. Some had some significant data issues, which meant that the performance of the algorithm was below the threshold required. And so there was in some PCNs, some remedial action that needed to happen in order to bring the data into line and make it usable. interestingly, in one PCN in particular in Gloucestershire, there was one GP surgery who had errors in their coding, and that affected the data accuracy and quality for the entire PCN, and held up the deployment within that particular network. There was lots of discussion around the AURC and how that, we talked about the threshold at the point of deployment, but also in how we monitor it over time and make sure that the technology continues to act as we expect. And at what point do we then decide that, that performance has drifted beyond what's clinically acceptable, and we, wish to go back to the vendor with a request for retraining? There was variation in local governance when we looked at PCNs and ICBs and how they wished to deploy. Some systems, the ICBs were super involved in how, in supporting primary care to deliver this. In other PCNs, it was much more arm's length support, and so upskilling of PCNs on digital clinical safety and their understanding was super important. The evaluation for this project is ongoing, so I'm afraid I can't give you the kind of real world evaluation beyond the validation that happened for the project prior to deployment, but that is in progress. And a lot of it comes down to the practical pathways which we work within. Euan talked about the hype of clinical AI technologies, and the hype versus reality. Absolutely stands in this particular case, because you could have the best performing algorithm, and this algorithm performed very well, to be honest. But actually, if you haven't got the pathways there to deliver the proactive care or the capacity to do so, then the data becomes a bit meaningless in terms of its real world use. And again, I won't spend much time on this, but confidence of the clinical teams in its efficacy and feeling uncomfortable with the unexplainability of the algorithm, was a particular challenge. Lovely. I think, have I got time to do the last couple of bits? I think you asked me to look at just my vision of AI into the future, Shu.
Yeah, let's do it.
Cool. Okay, so I'm not going to put any timescales to this because I think it's really difficult to do so. And some of this, I suppose, builds on what Euan was saying too. Interestingly, I think that what Euan said about legislation and legislation change will be some of the key gateways in where we see clinical AI deployments change over the coming years. I see that we'll see greater uptake initially in non-clinical aspects, so in clinical records, in patient administration. We will see continued uptake of clinically trained algorithms from a more traditional machine learning background, very much like I've talked about in terms of Brave AI. And we're seeing this, principally at the moment in diagnostics and radiology, but I think we'll continue to see it, in risk stratification and into remote monitoring pathways. I do see a scenario where we'll see it adopted more in high volume pathways for clinical decision support. And I do think it provides an opportunity for clinical care to move into the proactive space. We're all aware of the DASI shifts, and when you look at Brave AI as an example, it ticks that analog to digital, hospital to community, and treatment to prevention shifts all in one. And I can see further AI opportunities, AI is facilitating those opportunities. I do think that there will need to be some legislation change in order for large language models to be deployed clinically. And once that comes, I think it will come. And I think once that comes, it does open the door to much more AI augmented care and artificial intelligence driven front door to healthcare, and synthesis of medical records, and really building in that AI clinical assistant. I think this is really what Euan was talking about in terms of the AI enabled therapist. I think that's really when we see realization of that as a concept. And then at the moment, with any kind of AI deployment, a human has to be in the clinical loop, in order for the decision making to be, for it to be considered safe and deployable. I do foresee a future where there will be humans coming out of the loop in certain care pathways, particularly for high volume, simple first line care, which may end up being fully AI managed in the future. And I guess it'd be interesting. Euan gave a nice image at the end there, but at the point where robotics catch up with AI capability, really changes the what these technologies will be able to deliver. And so ultimately, I think as a profession, we should be thinking about how our profession may change from direct care delivery more into focusing on human interaction and relationships, more from treatment to prevention, as we talked about. Interestingly, I think we may move from more hands-off to back to hands-on, something that we've seen manual skills disappear from our profession over time. I think we will need to, rekindle some of those hands-on skills to remain, to keep the capability. And I think we'll move from more first-line treatment to more treatment in complexity. I think we'll move more from direct assessing and treatment patients to more auditors and monitors of the digital solutions that are being deployed as first-line treatment. And I think we'll move more from guideline-driven medicine to more digital twins and personalized medicine. This is particularly an interesting topic in genomics and in the medical professions at the moment. But it'd be really interesting how that impacts on physical health and physical capability. And that is me. I will stop sharing.
Thank you, Chris. I think we have someone unmuted. Can you please everyone stay unmuted, please? So, Chris, there's one question for you. If data drives decisions and AI tools require a large amount of data, how will they be able to collect the data that is required when so many different NHS trusts use different systems that collect different sets of data?
I agree, it's a massive problem. And, in that Brave AI example, it was already something we were contending with within primary care, where principally there's two major health record systems that were in use within that cohort. So taking that to acute trusts, which are using a much greater breadth of clinical systems, is hugely challenging. And I guess the question I would put to this is rhetorical, but there aren't many AHP or physio-led services which are particularly data rich at the moment. And even when there are, even when we do have data existing within services, I think my experience is the quality of that data can be pretty questionable. So Euan talked about skills and competence and education. That's super important. So is our data readiness as clinical services to deploy these technologies. If you don't have the data, the technology can't function.
Totally. It's a very big topic for all of us to discuss, for ongoing discussion. Cool. Thank you, Chris. Would it be okay for you to come back for a panel Q&A later around 11:30? I'm thinking about 11:30, 11:35-ish. Okay, cool. We see you later. Right. Cool. I hope you're really enjoying Chris's presentation, his project he was involved, and his perspective. Now, our next speaker is Dr. Munib Mesinovic. He is a Rhodes Scholar and postdoc in AI for Health at the University of Oxford, where he works in the AI for Digital Health Lab. His research focuses on explainable machine learning for predicting critical care outcomes, working closely with clinicians to ensure methods are robust, trustworthy, and deployable in real-world care. He brings an interdisciplinary background in engineering and computer science, bridging cutting-edge AI with practical healthcare impact. Let's welcome Munib.
Good morning, everyone. Thank you so much. I'll just share my screen. Can everyone see this? Okay, amazing. Yeah, that was a great introduction. Let's work for me. Today I'll be talking to you about more of the technical side on how we are building the AI that will help us in some of these clinical challenges. And I'll be talking to you about a few of our projects from graft survival prediction, patient survival prediction, and transplant setting to kind of how we're modeling new AI approaches using graphs and graph neural networks. As Shu mentioned, I'm a postdoc in the AI for Digital Health Lab, working with Professor Ting-Ting Zhu at Oxford. And a lot of my work is really on how do we make those big AI models interpretable? How do we help them tell us why they make certain decisions instead of just telling us what they're predicting? And how can we more efficiently learn from very large and multimodal healthcare data? And so kind of the trick I use is to represent it as a graph. And we find that sometimes neural networks find this really helpful. In terms of clinical applications, I work on a few projects, including with the NHSBT on transplant outcome prediction for kidney transplant patients. I work a lot on early warning and risk scoring in critical care. I worked a lot in lower and middle income countries, which I'll talk a bit about later. And now I do more and more treatment effect modeling, which is basically saying, had you had done this treatment or another decision, what would have changed in the outcome? Which is really interesting for recommender systems. So first, our work with NHSBT, we're looking at kidney transplant data, and every year there's about 6,000 patients currently on the waiting list in the UK for kidney transplant. And so we're looking at recipient and donor data and trying to learn a neural network that will match them and help us predict what will be the patient survival and the graft survival if the transplant were to occur for this match. And if this match was rejected, what is the predicted time to transplant for this patient, for the recipient? And so to understand this, we need to talk a bit about survival analysis. Some of you might be familiar with it already. So we don't want our machine learning models, our AI models, to just tell us, do this, do that, 0, 1, yes, no. We're actually interested in modeling the times to the event, so the risk dynamically. And why we want to do that is because then it's a bit more informative. We can show a clinician this is how the risk evolves over time. And we can compare between different patients or different groups of patients, how the risk shows up differently over time as well, which is more interesting. And when it comes to the transplant project, we're using a neural network called DeepHit, which basically helps us analyze all this clinical information, lab information, sensitization, types of dialysis, etc., blood group types, to figure out if this donor and recipient will have a good post-transplant outcome for the recipient. We can do some interpretability using something called Shapley values. So on the right, you can see a figure that says, for this particular patient, what are the clinical features that were important in predicting time to transplant? And so we can see sometimes the recipient's hospital, the blood group, the type of dialysis they're on, their age and sex are all highly predictive for this decision. What is even more interesting is we work a lot with NHS clinicians, but we were interested in validating externally our model. So we train about 30,000 samples from NHSBT, and without any further training or learning of the AI, we externally validate on UNOS data, which is American transplant data, much larger. It's about 10 times larger. And we show that the model actually remains quite robust. And now we're externally validating on ANS data, which is the Australian Transplant Registry, working with them. And hopefully similar results, we'll find similar results. And one of the key, I think, collaborations between us and the surgeons is that came about through this work is they're not just interested in the median time to transplant for the patient. They're interested in how confident or how certain is the model in this prediction. So on the bottom right, you can see using our novel uncertainty quantification method, we can provide confidence intervals on the risk curve over time. So this is the predicted probability for transplant for the patient on the waiting list. You can see that we can then give the confidence of the model in this prediction when it was right. The next project I'll talk about is my work with the Hospital for Tropical Diseases in Ho Chi Minh City, working with people living with HIV that are at higher risk of cardiovascular diseases in Vietnam. So we did a study of about 80 patients, 80 people coming in for their antiretroviral therapies over a year, and we collected PPG signals pulse oximetry signals. And using something called the foundation model, you can imagine ChatGPT is a foundation model for text. So we use the foundation model for PPG to classify and tell us whether or not this patient will have CVD in the next year. Yes or no, only using the PPG, no clinical features, right? And so we compared to existing risk scores like Framingham or DAD risk scores, which some of you might be familiar with, and we outperformed them, right? So this enables us to do remote monitoring of these patients without having them come into the hospital at all using these wearable PPG sensors. And this is work that's ongoing now over the next year. Now, a lot of my work, as I mentioned, is on dynamic risk prediction in critical care. Why this is particularly challenging is there's a lot of data, as some of you know, that's coming every minute, every hour sometimes, but it's also different types of data. So it's not just age and sex and ethnicity diagnosis. There's vital signs, there is ECG, EEG, there's imaging a lot, there's clinical notes. So how do we build an AI that can work from all of this together instead of just diluting the data into simple data that it can learn from? And so our kind of proposed solution is to model each of these data modalities as a graph. So you can imagine a radiology report can be a graph of its own, vital signs can be a graph of its own, and then the graph can evolve through time as the patient vital signs evolve or as the patient radiology report evolves. At the end, each patient can be represented as one dynamic graph. That's pretty cool just in terms of data representation. But what that allows us to do is to model the relationships between these modalities. What is it in the clinical notes that tells us what was in the vital signs 2 hours before? And actually, that information can be quite predictive for outcomes that we're trying to predict for. So in the ICU, we're looking at ICU mortality, we're looking at length of stay, we're looking at prediction of certain phenotypes. So if we look at heart attack patients coming into the ICU, this is more and more prevalent with our American data, where heart attack patients are going a lot to the ICU, and we're predicting for complications. So secondary heart attack or heart failure or pericarditis and things like that. And so we can do these kind of risk stratification, early warning risk scores using this very complex model. What is really nice about it is because it's a graph, you can at the end just extract it for each patient and you can just look at the graph and it tells you what the model learned, which is really convenient, really helpful in terms of analyzing it for the clinicians. Some of our results are here. At the bottom, you see these different data sets. These are all very large ICU data sets from the US and from Switzerland. If anyone has any clues on freely accessible ICU data set in the UK, please let me know. But for now, we're mostly working with from data sets from other countries. This is an emergency department data set from Stanford. And what we were really interested in is how does our model the risk over time for the patient. So on this figure, top left, our model risk prediction is red. These are the other deep learning baselines. You can see the true risk probability for the patients is the dashed line. And so I've seen in the ICU in use deep learning AI models, and they tend to fire all the time. They tend to have a lot of false alarms. So we were interested in our model actually being very close to the true risk and not overshooting in terms of over predicting for risk. So being precise and sensitive at the same time. And at the bottom, you can see kind of how accuracy over time degrades slightly, which makes sense because we're not actually feeding it new data. We're just training it once and then letting it predict for all future time points. So it does degrade, but it remains quite stable compared to the other alternatives. In prediction for ICU mortality in this case. And on HRID, we looked at circulatory failure as well. Now I'll talk a bit about my latest project called Critical MM, supported by UCOMAIN and EPSRC. And in this one, we're trying to actually do a lot of data prep for people. So ICU data from different countries is, you might imagine, logged differently and put into different databases, and it looks quite different. So in this project, we're trying to bring all of these data sets together and harmonize them and standardize them so that then people can do really interesting research on it. And we've already collected data from the US, Netherlands, and Switzerland. It's about 700,000 ICU stays and will be the largest ICU database or data set in the world. It will allow us to then train very large AI models because the more data you have, usually the AI models tend to perform better. And we can then, once we have a very large model, just easily add on more data or more tasks that we want the models to do. This is the kind of the advantage of these large foundation models. We are, of course, working a lot with clinicians to kind of help us figure out this uncertainty part that I discussed before. So can the model tell us how certain it is in certain outcomes, not just tell us what will happen, and the cost, right? What is the cost of hosting these models, hosting this data, running the models, etc. And so we're doing like workshops for clinicians and clinical professionals. So if any of you are interested, have intensive care or critical care experience, please reach out to this email. It's a really interesting project, and it'll enable us to kind of look at, like I said, very different kind of data at an international scale that has never been done before, and do really interesting things in terms of prediction and comparing across countries and within subgroups. And that's it for me. That's my email, and yeah, thank you so much.
Thank you, Munib. It's very exciting. We have a question for you.
Mhm.
Why don't we have sufficient data sets from the UK? Is there a known limiting factor?
Yeah, so I'm based in Oxford, and we have a very good kind of Oxford NHS Hospital Trust that is quite well integrated already in digital, the kind of the digital atmosphere. But for now, as far as I'm familiar, they have general hospital data. So Haven is like an electronic notice board. But I have not been able to find a kind of that someone has prepared an ICU database or data set and is working with AI researchers. But if any of you are familiar with it, please direct me to these sources. It would be amazing.
Fantastic. Yeah, if anyone have resources or wanted to collaborate, please do reach out to Munib. I'm sure it will be very exciting collaboration. Cool. Munib, can we bring you back for the panel Q&A later around 11:30? Cool. I will see you in a bit. Right, this brings us to our last speaker, Dr. Ip. So Dr. Chak Lam Ip is a medical doctor and a clinical research fellow specializing in stroke and data-driven healthcare. He works on an innovative telemedicine and AI-enabled stroke pathway at University College London hospitals, including video-based pre-hospital stroke assessment and real-world evaluation of AI tools such as Brainomics X Stroke. His work sits at the intersection of frontline stroke care, clinical research, and applied data science. Let's welcome Dr. Ip.
Thank you very much. Do you want me to share screen?
Yeah, if you don't mind.
Yeah, no problem. So just to make sure that it is working, that you can hear me and things. Thank you very much for the opportunity to present about this project that I'm working on. And just a little bit about me, I'm Chak. I am, as Shu has said, I'm a stroke fellow at Queen Square Hospital, and I work mostly in stroke. And particularly, I work in this video triage for stroke pathway, where if an ambulance crew thinks that they are suspecting a stroke in their patient, they would make a video call to the stroke team and to myself or my colleagues to perform a neurology assessment and make some initial recommendations for management plan. I also recently started a PhD program at UCL, and the PhD is very much focused on the similar thing of exploring the use of machine learning in stroke. However, for today, I was hoping to talk about a project that I'm working on that's kind of related to what I do in Queen Square, but also a little bit different, and it's about Nurevo. And Nurevo is a platform that we are developing that tries to improve the diagnosis and the monitoring of dementia. And it aims to use sort of natural conversation, a couple of minutes natural conversation to help with the assessment of dementia. And we'll talk a little bit more about the details later on. So why dementia, or more specifically, Alzheimer's is the disease that we are focusing on. So why Alzheimer's? Alzheimer's is a devastating disease. Some people say that it takes away who they are as a person, and it's a detrimental condition for the patient and also for the people around them. diagnosis is often quite difficult because we are all forgetful sometimes. So it's quite difficult to differentiate between just being forgetful and having an actual disease process going on. And I'm sure all of us have this experience of these awkward moments when we forget the names of the person in front of us and we are trying very hard to trick them into saying their own names because we really can't remember their name. And it happens to all of us. But for some people in some conditions, this is sometimes the first sign of a developing disease. And a lot of us are reluctant, even though we all are forgetful, a lot of us are reluctant to acknowledge that we are forgetful. So diagnosis is very difficult, especially in the early stage. But unfortunately, a lot of the newer medications, especially the newer ones, the monoclonal antibodies that target specifically the pathway that drives Alzheimer's, some of them are more effective or sometimes only effective if it's only early on in the disease process. So this is quite a dilemma for the patients who are suffering the condition. Traditionally, I'm sure a lot of you would know that the conventional way of diagnosing Alzheimer's disease is using a structured questionnaire that specifically assess their brain functions. They are time-consuming, they require trained personnel. But more importantly, a lot of people are reluctant to take those tests. And it's kind of understandable because if there is a potential, such a devastating disease and irreversible disease, we can sort of understand that people might be reluctant to accept that, people might try to avoid that. So it's a difficult situation. And what NeuRevo aims to do is to try to develop a new way to assess these patients and to use a normal, natural conversation. A conversation just like we would have every day. And that hopes to create a low stress and relaxed environment that would allow people to be more accepting to these kind of assessment. It also uses multimodal data, and again, we will look into that a little bit more later on. But conversation or a video recording of the conversation, just like how we have the recording of Teams just now, contains a lot of information that can help with assessing the condition that a person might have. And because of the development of the computational power and also the kind of analytical methods, we now have the tools that we can leverage this rich information in a video recording to hope to evaluate and to predict some of the risks of developing conditions. And the next couple of slides are about more of technical specific architecture of the machine learning. And I wouldn't go too much into details on those because it's kind of not the focus on the event today. But if anybody is interested, I will be more than happy to talk more about this or discuss more about this either later on in the event or on a different occasion. But one of the things that I want to emphasize is that this is not a new idea. The idea of using video recording or voice recording to try to assess the probability or severity of dementia has been around for many years, and there has been a lot of research in the last couple of years that we have seen. We are hoping to combine some of them to use multi-modality of data. So as we can see here, we want to use visual data, so the video data, things like how often you blink and how you move your facial muscles and how quickly you move them. We also want to combine audio data, so things like how fast you speak, how variable you speak, and how fluently a person speaks. And we have seen some of the research in the last couple of years that has already proven that some of these features or a combination of some of these features is associated with Alzheimer's disease. So we already know there is a foundation of literature that these kind of things can work. But it's a question of whether we can make it more accessible and more usable for people, and also potentially leverage some more information and data that's available on their video recording. We also use speech features, so things more like the linguistic or the semantic content of the speech, and again, that convey a lot of information that can be used for analysis. And the next two slides is about the actual machine learning architecture, and again, this is just to show what happens in the algorithm, and we're not going to go into details in this, but is just to say that there is a lot of different architectures and designs that we can use. It's not just one machine learning algorithm, and a lot of these designs are inspired or even driven by the development of large language models recently. And some of this type of data that we use, so for example, some time series data in the video or in the audio, lend themselves quite well to the methods that are developed initially, or maybe not initially, but developed throughout the development of the large language models. So we are using some of these methodologies. I think we will have to have at least 2 or 3 different architectures or different ways of building our machine learning models, and to test how well they perform and whether there is any pros and cons. And we are still working on this kind of fine-tuning the architecture and the model. And I'm sure there will be pros and cons for each model. It's probably not as simple as having just one model and we'll just use that as the best model. I think there will be different considerations for each of these approach, and we'll look into that. So just going back to the bigger picture. So what is the next step? The obvious question is how well it works and how accurate they are. I think we are working on trying to organize a clinical trial. So the foundation of the system is pretty much built. There is some initial data just with healthy people, just because we don't have the approval for actually testing that on patients. But I think the next big step will be actually testing the system on patients and to assess, I think 2 main things, to assess how accurate they are and also how acceptable they are, and make some fine adjustments on how we can make the system more actually user-friendly. I think that's an important aspect. There are many challenges to the development of this system, and one of them will be the regulatory approval. There will be a large hurdle of regulations, and it will be quite stringent, and rightfully so, just because we need to ensure the safety of the patients. And as with any machine learning model, we'll need a large sample size. And there are some database out there that are sort of open source, that, or at least that we can apply to obtain data to do some initial testing. But for the specific system and to specifically test how accurate it is, we will need to recruit our own patients and to collect our own data. So that is, again, a large hurdle, and we are working on that. So these are some of the developments that we are working on right now. And what about the future? So I think maybe it would be obvious to some of you that similar technologies can be used in many other aspects. And we focus on Alzheimer's because there is an urgent clinical need. But a similar technology can obviously use in many other things, in things like movement disorders, like Parkinson's, in things like stroke detection, or things like specific monitoring or evaluation of a specific symptoms. So things like spasticity assessment. We can use some of these technologies to help with the monitoring and the evaluation of them. And the overall goal is really to create a platform that promotes health and also promotes equality by using accessible and home-based methods to allow for a more closer evaluation and closer monitoring of neurological condition. So I'm sure there is a lot of things that we can talk about, but this is just a brief introduction of the project that I'm working on. Thank you very much for your attention, and I would be delighted to hear any comments or questions about this.
Thank you, Chak. It sounds such a rich project. There's a lot to explore. We have a question for you. So how is outcome account for the variability across different populations, i.e. people who speak different languages might present different non-verbal cues due to cultural variability?
Mm-hmm. Yeah, that's a very good question, and that is a key challenge. And I think there isn't a single solution to that. And we have seen actually some research teams and also some startup companies in different countries. I think one in Germany, one in Korea, and one in Canada working on a similar system. And all of them will have different cultural differences. I think one of the advantages, and I'm not trying to say that this will be the solution, but I think one of the advantages is the multimodal data. That's potentially some of the features of a patient will be different depending on their cultural background, but some of them may be similar. So things like visual features. So even though people from different backgrounds may respond differently to language prompts, or they might express differently in their own language, but some of the physical movements of their face may be similar. So for example, things like how quickly their gaze move in response to stimulus, or things like that. So I think the machine learning architecture will be able to give us some clues as to which feature is more associated with a certain outcome, and it might also be able to tell us whether it differs between different populations. And I think that will be able to give us some clues on what features is maybe a bit more universal and what features is more specific to specific populations.
That's great. I'm actually very curious about this project too, so I'm just going to take advantage of hosting this event, asking you a little more about, you talked about the 3 different companies located in 3 different countries doing similar things. Are there any movement, or do you think there might be a possibility for these companies to compare their algorithm or even share data, finding out what are the most reliable feature to look out, or what are the most reliable modalities to be validated in the future to detect dementia?
That's a great point. I think we looked into those startup companies, and also there are not startup companies, but research team. One of them in Japan, I think, is probably one of the most comprehensive research that we have seen. They similarly used different modalities, and they developed an app for the patients to use, and then they tested. And one of the challenge is the standardization, because obviously we are just recording a couple of minutes of conversation, and they different research teams and different companies may use different prompts and have different contents of what the person is actually speaking in those few minutes. So it will be difficult to standardize. But I think certain data might be able to transfer between studies and allow for more sort of comprehensive or larger analysis. So again, things like visual features may be more universal and may be more possible to be used for a cross-study analysis.
Perfect. Thank you again. So everybody, I think it's time to bring all our speakers back for a panel Q&A. Let me share the screen. I hope you're all enjoying the presentations. All the speakers, everyone's got very different perspective and different projects they've been involved and different ideas. I know we have a lot of questions to be answered. So first of all, we will invite those who already put the questions in the chat box. I believe, sorry. I believe, Richard, you have 2 questions to ask. Do you want to open your mic and the camera, ask yourself? You would like us to ask your questions on your behalf? I'm not sure if Richard is still here.
Yeah, I'm here.
Cool.
You put me on the spot. I just need to find my question now. I think my first question was just to Euan. Thanks for really interesting talk, and everybody's was really interesting. I was just wondering if you could expand a little bit more on sort of current status of digital and data education in the sort of current undergraduate landscape. From my very limited conversations, I think I've been sort of told it's been quite difficult to sort of fit in for various reasons. So, but I'd love to sort of just hear about that, because I just think that's a really important sort of future view, if we're kind of sort of looking for that digitally enabled workforce. So I figured this might be something you have more input on.
Yeah, Richard, good to see you, first of all. But yeah, really good question. So the physiotherapy curriculum is jam-packed. So we don't want to add too much more, because there just isn't enough space. Our students are already learning incredible amounts. We can't do them, or can't add in much more. What we're trying to do is a slightly different approach in how they learn rather than what they learn. So we're as part of the work with the Digital and Data Foundations programme that I put in the chat earlier, we've been working with the physio team at the University of East Anglia, and what they've done is with their population health module that they've used the digital and data foundations to use digital as a way of thinking of concepts of potential digital solutions to some of the population health challenges that they see, and then how they would use data to demonstrate the impact that they would have on the population health of a group within a certain locality. So they've been focusing on the town of Great Yarmouth, and then working with 4 different demographic groups within that. So they're working with the immigrant population, with young mothers, with teenagers and isolated elderly people, and a potential digital solution to improve the physical activity across those 4 groups. So they've done that. They literally just finished at the start of May, so we're currently, just tightening up the evaluation of that. We'll present it at CSP conference later on this year, so shameless plug here for the conference in October in Glasgow, but please get to that if you can do. But we'll be communicating it through other channels as well, and then we'll also be presenting alongside Dr. Kelly Walker, who is a CSP council member, but also part of the physio team at UEA, and we'll be presenting at European Region of World Physiotherapy Congress in Madrid in November about that. We'll also be publishing it, what we've done at UEA, as a blueprint for other physiotherapy courses to embed digital and data as a way of approaching different modules rather than that additional module which is just impossible to find space for. So watch the space for more on it. We're literally just, I think a week and a bit after that module closed at UEA, so watch this space for more information on that. But we're absolutely looking at ways to embed it as part of the current curriculum rather than an additional item that HEIs need to find space for.
Great, thank you. Yeah, no follow-ups. Did you want me to ask my second question? Sorry.
Yeah, if you want to ask a second question, we can go through them.
Okay, so this one was Dr. Munib. It was just around how the individual clinicians, especially kind of maybe new versus really experienced consultants, kind of interact with the decision-making tools, and whether you're able to sort of just talk around that, if you have any comment.
Yeah, that's such an interesting question. Thank you. I think there's a difference in levels of skepticism between younger and older practicing ICU clinicians. I think the younger ones are a bit more open to thinking about how they can use AI to make some things easier. I think for us, just based on previous models, experiences being deployed in the ICU, like I mentioned, there's a lot of false alarming. So I want to make sure there's something not ringing in the corner all the time. And so we're trying to make the models as precise but also still sensitive as possible. They often are a balance between the two. We have not prospectively validated yet, so we haven't seen yet in practice how they would do, which is I think at the end, the critical that I talked about, which is where we're trying to involve clinicians, because I think it's helpful to involve them as early as possible. What we see often is people will develop an AI tool, train it on a lot of data, and at the end they'll be like, oh, here's a product, use it. And then the clinician is like, well, you haven't actually looked at a lot of the things that I think are really important to build it. And so that's why we're trying to go backwards and say, how can we start from the beginning to start involve clinicians? And that benchmark will kind of have that decision-making as part of it. I think for us, it's also really interesting to include the uncertainty part. I think people don't talk about this enough. The AI model can tell you how confident it is. And I think that is really helpful with decision-making, high intense, high pressure environments like the ICU and the CCU. And so, yeah, that's kind of, I hope it answers some of your questions.
Yeah, no, definitely. I guess I'm thinking, I suppose it links back to that digitally enabled piece, just kind of being able to be presented with, say, that confidence, and then just how easy it is to then maybe slip into maybe it is a bit of sort of decision bias and just become reliant on it, which I know is a bit of an issue around something like this, but it's being able to understand it, which I think then requires that sort of that enabled bit, and I guess that comes from education. So it's a challenge, I think, but shouldn't be one that's stepped over. It sounds like there's some really great opportunities. So
Cool. Thank you.
Thank you both. We have our next question from Tanzania Haku. Not sure if you're still here, and do you want to ask a question yourself, or do you want us to ask it for you?
Yeah, thank you for that. I can ask that questions. I was just wondering because I work in NHS Trust, so we don't use any like for even for documentations for like artificial intelligence and beyond. So how can we use implement this artificial intelligence and beyond? So we use like a system. One again, different trust use different clinical systems. So how we can implement the artificial intelligence in our NHS documentation and beyond, please.
I'm happy to start with that one, Shu,
Yeah.
and thank you. That's a fantastic question. So the main thing I would say is don't go lone wolf on this. Please don't do your own thing. Please seek guidance from line management and from the digital experts within your trust, because we don't want physios anywhere going out with the realms of what they should be in terms of from a regulatory perspective, and or it gets us all into a bit of bother. So please don't separately do your own thing. Reach out to others in your organisation. It's likely that most of the big EPR providers, Chris earlier spoke about the moving towards monopoly, that there some EPR providers have, but most EPR providers, whether they're the big two or whether they're others, will have interoperability with some sort of ambient voice technology and or some sort of clinical documentation support tools. So different levels of AI supported documentation. It's likely that your organization probably has to pay a little bit extra to have that functionality opened up within that EPR. So even though your system that you use might have that functionality possible, it may not be usable within your trust. So again, seek assurances from others within your trust. I do know that System 1 does work with Tortoise, which is an AVT, an ambient voice technology provider, and it will be compatible with Heidi as well, because other physios and other trusts are using that. It doesn't mean it will work in your trust yet. So what I would suggest that you do is you speak to line management, physio line management in the first instance, to see if it's available, and then also take that to your digital leaders as well. You know, your chief AHP information officer, if you have one, or a CNIO or a CCIO, which you're probably more likely to have. Take a question to them and ask if the functionality is possible. From a technical perspective, yes, it's possible, but it may not be from a licensing perspective possible just yet. I hope that answers your question.
I think I agree with everything Euan said, and I think it would just be key to, if we're talking about interoperability, we're talking about the technology you're looking to deploy interfacing with existing systems, and you know that may be essential, but it also may be something that is not essential. It depends on the clinical pathway that you're looking to deploy it in, and so you know, just because something doesn't integrate with System 1, it may still have clinical benefit, and there may be ways that it fits within your organization anyway, but it does have to be done safely and with the right due diligence.
Thank you both.
Thank you so much both for your support of this question. And we have the next question. I think, Chris, you might be able to help with. So what is the pathway to become a digital AI fellow? Okay, so there's an annual intake for the Clinical AI Fellowship, which is hosted through NHSE, and then so it opens, you might have more up to date on this, Shu, but it opens in the autumn generally, I think, and you make an application. There's an interview process, and if you're successful, you're offered a place. So I finished my fellowship last year. And Shu, you're on the new cohort. The scope of it has opened over previous years. So prior to the cohort that I was in, it was for medics only, and was opened up to nursing and AHP in the cohort that I was in. So I believe that there are
we are seeing more representation from other professions within the fellowship, which is fantastic. I really recommend it to anyone who's interested. It gives you a lot of the learning is self-directed, but it gives you the time to be able to dedicate to learn some of the skills and technical background knowledge, which is really helpful to understand these technologies.
Yeah, totally. I would agree with what Chris said. I am going to start this August. It's very competitive, but this AI fellowship is all about implementation. I know there are other AI fellowship across the country. Again, if any of you interested in knowing more about fellowship opportunities, you can jot down your contact details. Maybe we can share with you in the future through the network. So yeah, please scan the QR code at the end of this event and tell us exactly what you'd like to know in the future. So we have another question from, correct me, I'm really sorry, I'm not sure if this is the right way to say your name, Awanga Lecky. This is for Munib. So how do we prepare frontline staff with the observable competencies to interpret these aggregated outputs under high pressure conditions without falling into automation bias?
Yeah, I think Richard touched a bit about that before with kind of over-relying on it. I think all the figures I've shown you is not at the end what the tool would be providing to the clinician. So that was just results. I think for the transplant project, because we're doing clinical trials, so we're actually building an API. We have a design team, so very experienced professionals who have kind of experience how do you communicate very complex technical kind of information to practicing clinicians. And a lot of the time, the less is more. So the kind of simpler something looks like a simple curve rather than all the detailed information is really helpful. And so we try to think about what is informative amount, but not overburdening the clinician visually or information-wise when we communicate what the tool is doing. A lot helpful for this is the interpretability we're doing in our models, that the models can tell us transparently what's happening inside in terms of the learning. So I think that helps with confidence and trust. And we also show them actually when the models don't do well. So when the models are not performing well, why? And on which groups. So I think that helps a bit with the over-relying on them and that they can still remain skeptical. Yeah. I hope that answers your question.
Cool. Thank you, Munib. Can I ask if anyone else have questions? You can raise your hand. If not, we're just going to close our today's session. So we're very grateful for having all our speakers today and your participation from our audience. I hope you have gained more insights on how AI could shape our clinical practice and what are the opportunities to come. So please do scan this QR code, give us some feedback. Your answers can really help us to improve the event organization in the future. You would also have opportunities to tell us what other clinical AI topics you want us to cover, and leave your contacts to us if you're interested in specific opportunities or if you are looking for collaboration. So for those who might be interested in joining us at the London Regional Network as a core team members to be able to plan events like this one, please do stay on. We have a very short recruitment promotion session. So for those who are leaving the meeting room, have a lovely weekend ahead. It's going to be a very busy weekend for everyone. Thank you again.
Thank you, Shu.
Thank you.
Thank you.
Thanks, everyone.
Thanks all.
Thanks very much.
So we're going to stay here to continue with our London Regional Network recruitment session. I hope everyone have scanned the QR code to give us feedback.
I was just going to comment on Geeta's message in the chat. Unfortunately, it is only for London-based CSP members, but I definitely recommend getting in touch with your West Midlands Regional Network if you haven't already. And I can put a link in the chat to how you get to contact them if that's helpful.
Okay, let's share another PowerPoint. Can everyone see the slide?
Yeah, we can, but it's oh yeah, we can now.
Yeah, cool, brilliant. So the CSP London Regional Network is officially opening for recruitment now for our core team members. So we represent over 12,000 members across London, from students to newly qualified clinicians to senior researchers and managers. This is your chance to step beyond your day job and help us empower that massive community. So we aren't just a committee, we are the engine room for regional development. Okay, having a problem to move on the slide. There. So what do we actually do? We define ourselves as the bridge. We sit right in the middle, acting as the vital link between you, the frontline CSP members in London, and the national CSP body. Our mission is mainly threefold. First, organizing events. We don't just pick topics at random. We listen to our members' needs to create tailored sessions on clinical mastery, career progression, digital innovation, and leadership. So second, share resources. We ensure national updates and evidence-based practice actually reach to the clinical floor. Third, regional influence. Crucially, we represent the London voice at national committees and the annual representatives conference. We make sure that the unique challenges we face in London drives national policy change. So you might be thinking, do I have enough experience for this? The answer is likely yes. We aren't looking for a specific job title. We are looking for a profile. We want people passionate about physiotherapy, people with a proactive can-do attitude, and those who thrive in a diverse interdisciplinary team. In terms of commitment, we keep it sustainable. There's one mandatory 1 hour monthly meeting. Beyond that, we ask for about 1 to 2 hours a month for project work, which varies depending on which event we're running. Different team members have different focuses, whether that's social media, member engagement, or event planning, but we all work together as a cohesive team. And please refer to our webpage for more details. What do you get in return? This isn't just a volunteering work, it is strategic leadership development. So first, you will experience a skills surge. You will master organizational and communication skills that are usually reserved for senior leadership roles. Second, you will build a network. You will be connecting directly with national CSP stakeholders and high-level external professionals you'd never encountered in your typical clinical rotations. Finally, you get real impact. There is no better feeling than seeing an idea you had in a committee meeting turn into a real-world change. As we like to say, we facilitate regional member development strategically. So if this sounds like a next step in your career, we want to meet you. We are hosting 2 recruitment open meetings via Microsoft Teams, one on the 28th of May, the other one on the 9th of June, both at 7 o'clock in the evening. To get the link, and please express your interest by scanning this QR code on the screen you can see. In your message, just tell us briefly who you are, why you want to join, and what you hope to gain from this role. Don't worry about having a perfect CV. We value your perspective and your drive above all else. So scan the code, complete the form, and let's work together to shape the future of London Physio Network. So thank you very much.